Hi, my name is Tim Orr. I'm Director of Residential Services with Island Health. And Daniel, I need to tell you that you maybe don't use the word facilities. There's also a growing feeling we shouldn't be using the word residential. So we're going to have to change our vocabulary here as time goes on. So Island Health is responsible for providing care on Vancouver Island. We have Greater Victoria in the southern end of the island. Now we have 350 people there. In most more populous countries on the planet, that would be considered a small town. In Canada, we call it an urban area. So we have an urban area, and then as the farther north and west you go, the smaller and more rural we get. We provide about 5,400 complex care beds. 2/3 of those are done through our contracted partners. We have about 1,000 assisted living. All of those are through our contracted partners. And we do about 2.6 million hours a year of home care. Just over half of that is done through contracted partners, and we do the rest. And we tend to provide more services within the health authority the further remote and rural we get. It's easy to get contracted partners in urban areas, medium-sized towns. It's really hard to do contracted partners when your home support worker has to take a water taxi to get into a little island to provide home support. So it tends to be that direction. A bunch of my points have been already addressed here, so I will just really skip right over a number of these. A couple of things that I will mention. I'm speaking from a health authority perspective. So the collective agreements that we have are the provincial collective agreements, and I think there are some things there that could be thought about as we go forward. One that's been mentioned already is the wage and benefit differential between sectors, whether it be community, facility, mental health. There are some challenges there. And frequent posting between jobs, and I'll speak more about that later. We're seeing increased utilization of healthcare aides in acute care. That's great for acute care. It's the team-based approach that we all want to do. It creates increasing demand on a very limited resource. We've talked about ESL or immigrant workers being our primary pool. ESL challenges are real. Heavy accents combined with an aging population with hearing deficits creates a real challenge. We need to find ways to support our new immigrants to diminish their accents and be able to communicate more clearly with our clientele. Increasing care hours in residential we're well aware of. We've not talked about the probable large increase in demand for child care workers. Maybe not exactly the same applicant pool, but I suspect there's a large overlap, and that's going to have to be included in our discussions. The other thing that I would like to focus on just a little bit here, and it's not urban or rural, it's the changing expectations of our workforce. And frankly, young people don't want to graduate from school, become a cog in a wheel, wait for 5 years to get enough seniority that they get the rotation they want, and then live for the promise of a pension 30 years down the road. They want more immediate rewards. They've got shorter term goals. They want jobs that fit with their lifestyle. They want personal and timely recognition when they do a good job. And what does this say about our collective agreement environment? I don't know. But I do think it's something that we need to be thoughtful about, and the expectations of our younger workforce need to be addressed one way or another in our system. Housing has been mentioned. It's not just a large urban problem. In the Comox Valley, you can't rent a house for love nor money. How do you attract workers, if you can't find a place to rent? And in small towns, that's a real big problem sometimes. So sometimes it's the cost, sometimes there just isn't anything available. Okay, urban challenges. Regularly, care aides are working for multiple employers. Sometimes that's a full-time job and on a couple of casual lists. Sometimes it's 2 full-time jobs. All of the casuals are on multiple casual lists. So it looks like we have lots of casuals in the system. If every facility says, oh, I have this many, I have this many, I have this many, you're all counting the same people. We're all competing for the same people. We're counting them multiple times, but availability is really limited. So, we just I don't know how we fix that. You know, it's expensive to live. People are working more than one job. I just got flagged there. I mean, I've got to keep going. Well, let me go back one. Employee churn within and between workers is huge. It's big in the health authority. It's big between workers. It is causing a real problem for continuity of care and a real burden for the system. Rural challenges, small applicant pool, limited local training, and we've talked about that. If we can't train people locally, it's extremely difficult to attract people to small towns. We have collective agreement barriers to a really flexible workforce in small towns. Facility subsector, community subsector, mental health. You know, when that person takes a water taxi and goes to the little island to provide care, wouldn't it be nice if they can do a little mental health counseling and provide home care while they're there, rather than sending two different people to do the same job? Or wouldn't it be nice if the community person, you know, when they're busy in the morning and it gets a few hours, could go work in a facility adult day program for a few hours without having collective agreement barriers? So I think there's some things that we can do on that front. It was already mentioned, you can't recruit a care aide to a small town if their partner can't find work. I don't know how we fix that one. Some of the strategies, I think we do need to promote healthcare. When I see healthcare, it's about the risk of violence, it's about the stress. We got a big image problem, and I think we need to start communicating. I mean, Daniel, absolutely right. We need to start singing a new song, and we need to get it out there that this is an attractive career. Local training in smaller communities. I think we need to take down the barriers and attract Aboriginals into healthcare. In small towns and rural areas, there's an untapped workforce that could just do an amazing thing for our sites and for their communities. Programs in high schools we've talked about. We talked about trying to make healthcare attractive to younger people. On the island, our home care team, and a couple of folks are sitting here that have done it, have done a lot of redesign, neighborhood model healthcare. The intent was to make a better experience for the clients, make the system more efficient. One of the unintended consequences has been really significantly increased employee satisfaction. It's more team-based, it's more flexible, there's more support for workers, and workers are happier in a more team-based system. We need to find ways to try and meet the needs of younger people, and those needs aren't met through a promise of a pension. I mean, we're reading right now, people that gave their lives to Sears are now wondering if their pensions are going to be there. Frankly, young people today have grown up in an environment where they don't believe in promises in the future. They want to see rewards today. And we need to figure out how to do that in healthcare. We've talked about the need for more full-time positions. I think we need to find ways to do that. In Highland Health, our workforce is made up of approximately 50% full-time, 25% part-time, 25% casual. Not everybody wants full-time, but everybody wants a commitment to steady work. They want a regular job with benefits. We do need to find ways to increase that for people. I think there's some discussions that can be had with the collective agreement language that could move us, a little bit to addressing some of these. Decreased churn. I mean, frankly, a care aide can take a full-time job and then bid into a part-time line over summer when their kids are home, bid into a different, location, different line, go back to full-time in September, and then do a different one at Christmas because the day's off better coordinate with my family events over Christmas. People can bounce in minutes, and that doesn't provide quantity or quality continuity of care, and it certainly costs the system in training and orientation and just the churn. We need to find ways to meet employees' needs and to create a little bit more stability. We need to create more attractive schedules. I hear all the time about these 6-day blocks. I don't know anybody that likes them. Surely we could fix that in the collective agreement. More flexible workspace in smaller communities. We talked about that. Can we take down some of the barriers between sectors and the wage gap between facilities and community? I think there's lots of things we can work on. There's no one magic bullet, but we certainly have a task in front of us, and the time has come for action. We do